Hi, I'm Dr. Sam Lamb. I'm here with Dr. Shadi Zari from Saudi Arabia. I'm in Dallas, Texas. I am a hair surgeon in practice about 21 years, and today's topic is going to be on female hair loss and sort of how we address women in our practices. This is going to be sort of a free-flowing discussion. There's not a strict format to it. We'll both sort of moderate each other, but I'll serve as sort of an unofficial moderator. A little bit about me. I've published 9 books on hair restoration. And really, I'm passionate about hair. I've run a course for about 15 years on hair surgery. And Dr. Zari has published a lot of really amazing articles on the subject as well. And I'm sure as much as input as I give, I think I'm going to learn a lot from him. So I'm going to toss it over to Dr. Zari. Could you give me a little background of yourself as well for the audience?
Hi, I'm an American board certified dermatologist and a fellow of the Royal College of Physicians and Surgeons of Canada. So I did my residency in McGill University in Canada, and I'm currently practicing in Jeddah, Saudi Arabia. I'm mainly focusing on medical hair loss treatments, and I run a hair transplantation practice, which I've been running for 15 years now.
I know you have a lot of experience with female hair loss. Can you tell me a little about how does it how many women do you see in your practice? What percentage for medical and surgical treatments?
So interestingly, 70% of patients who present to me, to the clinic for hair loss are females, and many of them are coming initially for a hair transplantation. But after the consultation, probably I would say only 5% to 10% maximum of those patients would end up with hair transplantation, as opposed to men who present to my clinic for a hair transplant. Probably 50 to 60% of those would end with the hair transplantation.
I'll tell you my percentages. About half of my patients for consultation are women. So I think both of us run a pretty unique practice, because I would say the vast majority are probably seeing 90% men or 95% men. And out of that half, I would say half of those would go on to surgery. So about maybe 25%. So total of my volume of surgery for women is probably about 30% for women and 70% for men overall. Let's talk a little bit about medical therapy, and then we'll go into, actually, let's talk a little bit about let's start with medicine. Tell me a little bit about your approach to medical therapy.
So the approach I use is I start most of the time with topical minoxidil, and it's the only, as we know, it's the only FDA approved medication for genetic hair loss in females. Most of the treatments I use are off-label treatments. As we know, most of the medical treatments are off-label. So it depends actually on the severity of the case and whether the female wants to become pregnant or not, because most of the women I see are in childbearing age who want to become pregnant. So those I'm limited in treatments. So with the topical minoxidil, I would use autologous treatments. So meaning autologous treatments, PRP, platelet-rich plasma sessions, and autologous cellular micrografting, which is Regenera. And I've published on that, like the largest study on female hair loss. Then if the females are willing to be on strict contraception, I can use oral minoxidil, low-dose oral minoxidil, DHT blockers such as oral dutasteride, oral finasteride, and dutasteride injections. And also in a few patients, I also use spironolactone. So this is a nutshell of the medical treatments I'm using.
So just to clarify for the consumer out there, when we talk about FDA clearance and off-label, so FDA, you have to have a single indication for use in the human body that goes through a 3-phase clinical trial. But a physician, at least in the United States and maybe in Saudi Arabia as well, can use a product so long as the off-label. In other words, it's not indicated for that reason, but off-label for some other purpose, so long as there's a consent and a dialogue with the patient about the pros and cons, just so that people understand the difference. So it's legally possible to use it in different ways. So for me, I've really migrated away from biochemical therapies for women I think they are very effective. I find that, because of some of the side effect profiles that can be there, especially with women of childbearing age, I have migrated over to sort of natural therapies. A lot of times when we think of natural therapies, we think about therapies that are not very effective. In the world of medicine, we use the word homeopathic in a very derogatory way because we think it's just not going to do much. I actually don't use a lot of oral nutraceuticals or low-level laser, which are the two that usually come to mind. I don't want to say that they're bad. In my hands, I don't find them to be very highly effective, although I do prescribe them. I do have that, but not to a high extent. The therapies that I use, some of them I'm working on right now and developing, so I can't release everything, all the information. And I know this is a consumer ad. I'm not trying to promote myself. But one is I use sort of plant-based growth factors. And so what I find with different therapies, and they're different machines that deliver this without needles. So one thing nice is without the pain of injection with PRP, it's almost like a PRP, but at a much higher concentration, in my opinion. I've found them to be more uniform in the results without the discomfort or the shedding. And it's similar to, if you think about HRT or hormone replacement therapy for postmenopausal women using plant-based hormones, I found that these growth factors work more consistently for women. I have a spray. I do have a disclosure with that since I have developed it, but I really use it all the time. It's called FolliFlow. It's on Amazon, but it's basically a product that I find particularly helpful for shedding. I use it perioperatively, and it's for growth. It does grow, but not to the extent of my other therapies. And so that is something that I really love in terms of just managing shedding. And finally, I use something that I'm in the process of patenting, so it's not out for another year, so I can't talk too much about it, but I use botulinum toxin or Botox to manage hair, and it's not in the scalp, believe it or not. So it's a little odd, and I will have that disclosure in about 1.5 years, but these are just sort of odd things I'm doing. And so because I'm doing some weird things, I am getting results that I like. Now, I do love biomedical therapies. And so the role for me when I see biomedical therapies, especially, I don't know if you're seeing this, Shadi, but a lot of use of exogenous testosterone. In other words, like postmenopausal women are taking testosterone for their sex drive. Do you see that as well in Saudi Arabia?
Yes, but to a more limited extent probably than the US.
Yeah, it's becoming very popular. And so when I see women that have more frontal temporal recession, and when I see that there is a preponderance of issues with their hormones being off balance, like testosterone, especially when there's a history where they say, I've been slowly thinning for 20 years, sort of like with men on testosterone. All of a sudden I had this acceleration for 2 years, and I get a history, by the way, I've been on testosterone for 2 years and I don't want to give it up because my sex drive is better, everything is better. I want to maintain that. Then I definitely, not definitely, but most likely will go toward a finasteride, so long as they're, of course, most likely they're in the non-childbearing age, to do some kind of biomedical therapy to help them with that. So yeah, and I lean toward oral minoxidil just because of the convenience and the power. But as everyone knows out there, it's about a 15% chance of having hair growth, and it's not great. I start them on a little higher dose. I don't know, it's higher than what you start with. I go at 2.5 milligrams. Do you start lower than that?
Usually I start at 0.625.
Okay. Yeah.
And then the maximum dose I go to females is 1.25 milligrams,
okay,
because of the hair growth, the body hair growth in females, which is.
What have you noticed with hair growth issues at 0.625 or 1.5? You noticed a big difference between those two doses?
Yes, I mean, obviously, the more you increase the dose, the better the result. But I always start with a lower dose and increase gradually. But again, as you said, like, it's totally different approach when you're approaching a lady who's premenopausal, who wants to become pregnant.
Yeah.
When you're at the postmenopausal stage, you have like a green light. You have so many treatments that can use, more other options. And I always believe that combination treatments is the key. You can't just depend on one treatment. These things are multifactorial, and the more treatments you use, the better the result. It creates a synergistic effect.
Do you usually start them if they're not going to have children or they are sterile? that, or postmenopausal, do you just like to start them on a combined medical therapy? And if so, how do you differentiate between the childbearing treatment versus postmenopausal because of the hormone changes? Do you have a different cocktail or regimen you give to those two different subsets?
As I mentioned, like in premenopausal or childbearing age, I'm limited to topical minoxidil and autologous treatments such as PRP and autologous micrografting. But postmenopausal, I always like to put them on a DHT blocker and low dose oral minoxidil along with the regenerative therapies if needed, you know.
Perfect. Tell me a little bit about, you said a very small fraction of your women go on to surgery, and I know you've published some amazing studies. Would you like to talk a little about your decision tree of what is a good candidate in your opinion, and maybe some of the studies that you have to back up that opinion?
Yes, so this study was published last year. It's involved 1,000 females who presented to my clinic with genetic hair loss and had thinning hair and were diagnosed with female pattern hair loss. So of those patients in the study, 1/3 had involvement of the occipital area, which is the donor area for hair transplantation. So they had a higher percentage of thin hairs and medium hairs, which medium thickness hairs, which are unsuitable for hair transplantation. Also, ironically, the severity of the thinning in the frontal area, the more occipital involvement there was, and they were unsuitable for hair transplant. So I think this has a major implication in hair transplantation in females. So usually, as we know, females present with diffuse thinning, and they can either present with a diffuse thinning with preservation of the frontal hairline, which is more evident when they part the hair in the middle, which is called the Ludwig or Sinclair scale, or they can present with diffuse thinning, but have more of a triangular shape or a Christmas tree pattern in the front, the Olsen pattern. So in my opinion, the first presentation was that diffuse thinning is unsuitable for hair transplantation because you have a large area and you have a limited donor supply. Mm-hmm. So on the other hand, the Olsen pattern, which you have a triangular shape, you can transplant into that area only, depending on the donor area. But both ways, whether I decide to transplant or not, I usually start patients first on medical treatments for at least 1 year. The reason is because I believe genetic hair loss is a chronic and progressive condition. So they'll need these medical treatments whether they do the transplant or not for life. And the goal of using these medical treatments before hair transplantation for at least 1 year is first to assess the response to the medical treatments and try to avoid the hair transplantation. And in case they need a hair transplantation later on and the medical treatments are unsatisfactory or haven't reached the desired result, the medical treatments they use are going to improve the thinning of the hair, and they're also going to improve the donor area. So in my opinion, it's even going to complement the hair transplant and make it more successful, and the patient's going to have a better outcome at the end.
I think that's a very conservative and reasonable approach. And, for me, that's probably why if I see issues in the donor area, I'd lean more toward an oral biomedical therapy than a topical, because it's very hard to globally apply minoxidil everywhere or topical finasteride all over the place to get access to the donor area. So my philosophy is a little different from yours, and I think it's nice for the consumer to hear different opinions. Neither one is right. I think you have a ton of experience out there, and I think it's nice to hear this incredibly large study that you've done that supports your approach. My approach is a little bit different, and so the reason I have a higher percentage of my female patients that are undergoing surgery is that I find that in my hands that I feel like it's a safe procedure. So just to give you my strategy of how I deal with women is that, first of all, I sort of divide it mentally into stable and unstable. So if they have unstable hair loss, they are not a candidate for surgery, period. They need to be stabilized and observed. If they're stable, then I divide that into long-term stable, short-term stable. Short-term stable to me still follows maybe in the category of instability, and I may have to give a little more time. What is that duration? It's arbitrary definition. If they tell me they've been thinning for 20 years or so, or 10 years or 5 years, and there's no other signs of weird scalp problems, a scarring hair loss that would prevent me from doing it, and their hormones seem to be relatively stable over that period of time, I lean towards surgery for them, and there's several reasons why. So first of all, diffuse unpatterned alopecia or DUPA is what you're describing, which means compromised donor, which is absolutely true that those grafts could be susceptible to loss after transplantation. So for men, particularly men in their 20s, 30s, and 40s, I'm very gun shy to do any kind of surgery if they have diffuse unpatterned alopecia. And to be very honest with you, even if they're 60 or 70, I would be very careful and not want to do it. But when you get older men with diffuse unpatterned alopecia, if it's early, I find that with some medical therapy, especially orally, they can maintain those grafts in a way that are surprisingly favorable, so long as you find the right male. For women, I find it to be even more stable in the sense that I've taken grafts that you would think won't survive. And I've been in practice over 20 years and following my patients over a long time. And those fragile grafts that you think won't survive. And even if they're not on biochemical therapy, like a finasteride minoxidil. So I find that those grafts that are not, that we think, by textbook answer, that we wouldn't transplant, they actually do survive well. But especially if you are afraid of those grafts not surviving, to be on some kind of oral therapy. And usually those women are in the postmenopausal setting anyways, where you're not worried about childbirth interruption of that regimen. The second thing is that with women, I always try to focus on a strategy, because women don't have the option to shave their head. So with men, I'm always thinking, I'm incredibly conservative with men. I deny a lot of men surgery, and I deny very few women surgery, which is interesting, because with men, when they're in their 20s and 30s, they could always shave their head. They could have that diffuse unpatterned loss, which will cause serious problems in graft survival. And then they're stuck with they can't shave their head. They have to do scalp micropigmentation, a camouflage, or other problem. Women don't have that exit option to shave their head. And they are usually incredibly grateful for any grafts that I can give them. So what I talk about is sort of a strategy, which is what I call a TL reverse L. So essentially, it's the central forelock in this front is the horizontal limb of that TL. And then whether it's in the middle, which would be a T, an L, or reverse L is the part. And so that vertical limb is the hair part. So I tell women that if we can get a strategy to focus on the areas that bother you, I think you're going to have a nice result. And most women are very grateful for that. And if I have enough donor to do it, I also come up with a pattern that I call a dumbbell, which is really a silly name, to be honest with you. But it's a concept that a big circle in the front, what you talked about, the Elise Olsen Christmas tree tapering to the back, and then a small circle in the back. Because I find that women don't really, for the most part, lose their crown, but they're very bothered by the volume deficit in the crown. So you don't need a lot of grafts going in a very wide area. They just need a little bit in the center, create some lift. And I've lectured a lot about crowns. And so I'm really focused on giving women some of that back. And sometimes I find that just surgery is all they need. Actually, they don't even need the medicine. If they are relatively stable, they don't want to take medicine, and overall they seem to be in a very good situation where I have just enough donor to hit the key zones. I may not put them even on medicine, which sounds sort of heterodox, against the mainstream, but my opinions don't always follow the mainstream. And that's why it's a good conversation that we're having. Again, you're not wrong and I'm not wrong. We're both having different opinions, and we both have a lot of evidence to support how we practice. And so then for me, the product I mentioned, again, it's unfortunate disclosure, is really all I use to stabilize them over 6 weeks so that they have less shedding. Because the biggest problem with women, as you know, is postoperative telogen effluvium, meaning that they can thin out for the first couple of months, which is very devastating. So that's the number one thing I deliver for women. So it's sort of a strategic vision of how I can limit and focus on the transplants. And I always undersell them. I always tell them they may need 2 sessions. I'm not going to get everything covered. It's very rare that I can do that. But a lot of women are just grateful that they get hair there that gives them some volume, some shape, some density. When they look through, they don't see the loss. Or I may just prioritize the frontal temporal recession and do the rest with medical therapy. And that's sort of the gray zones that I work with, Tell me a little bit about with surgery, when you do it, are you mainly FUT or strip, or are you mainly FUE? Do you do a combination, and why?
Usually, I do a limited amount of it. I've trained in New York with Dr. Walter Unger in 2009. So all my training was strip surgery, FUT.
Yes.
But later in the years, FUE developed in a better way, and the tools we have, you could have achieved closer, very close results or similar results to FUT. So, and now with the long hair FUE, you can even perform FUE without having the shaving of the hair of the full effect, So it's a combination of both, but mostly now I'm doing FUE because of less post-operative pain and tension that they feel for a few weeks. Like the recovery, I think the main thing now of FUE over FUT is the recovery. Like the pain post-op is different between FUE and FUT, but both methods have a role depending on the patient. Whether you want to do a very large session, of course, you're going to gear towards an FUT. If you have a limited session, I think FUE is the way to go.
So it's really good that we have such polar opposite opinions, because I think it's great for the consumer to see there's no right answer. It's just different opinions. So I do 100% FUT in women, and I do a combination FUT and FUE in men. And that's obviously, we're not discussing that in men. Sort of my theory behind why I do FUT in women is, non-shaven FUE is a very difficult, laborious, longer process to harvest. The other thing that is sort of a bias for me is that when I can take a small strip and remove it, I don't reduce the visual density or the total density over the backside. It's only in a very exclusive area. So I think I can reduce the risk of overall thinning in the donor area, especially if they start with a thinner density to begin with, because women hate sort of a loss of volume. The other thing too is that I've invented a technique. So during the treatment, I do IV sedation, so they don't feel pain. In fact, I can actually sedate them a little bit deeper with an FUT or strip compared to an FUE, so they are pretty much knocked out. So there's no discomfort during the procedure. The second thing is afterwards. What I found with FUT in terms of the pain, which is something that people talk about, is two things. One is during the surgery, I use a bucket of tumescence. So I pull that strip 8 miles away. I spend a long time with tumescence so that they're very far from the occipital nerves, and I'm very, very careful in terms of harvesting to minimize any issues whatsoever. And then I find is that, so I would say 80% of my patients afterwards have almost no discomfort, but about 20% have somewhere between a 1 or 2 of pain. And then there's some, I've had a handful that have a 6 or 8 out of pain. The technique that I have published on in my recent book, Hair Transplant 101, and the technique that I've talked about and lectured on at the ISHRS, I've actually since modified it again, is, and I would, if physicians are watching this, I would love for them to know this, including yourself, is I can make that pain really close to a 0, if not entirely 0, within 1 second. And so my patients do not have pain afterwards. They really have almost no pain. And so the technique, just for the physicians in the audience and also for the consumers perhaps, is that there's 3 little holes in the back of the head that are basically below the superior nuchal ridge, and then on the back, on just the side. These 3 little circles, if you put some very dilute Botox in, it's a meridian channel release point that goes up to the entire incision. Most of the central incision, and that whole pain is down in 0 seconds. And it doesn't make sense intuitively that botulinum toxin would actually knock it out. And the number of units, 1 to 2 units. It's not even equal to a crow's feet. And then I find for the lateral edge of the incision, if I just put a little bit right at the mastoid, the central mastoid region where the bone is prominent, it wipes out the pain laterally. So the first question I ask my patients on post-op day 1 is, are you having any discomfort? Where is it? And if they tell me I don't have much, I mean, I'm lying on my right side, it's just slightly achy, I encourage them. I said, look, I can erase that right now. It should be gone. And the way I document it is I take my hand and I apply pressure, and they say, well, because they don't know if it's gone, right, until they go to sleep that night. So I pretend I'm the pillow, and I will put pressure on the areas where there's discomfort, and that pain is literally either 0 or it's 0.1 out of 10. So they don't have discomfort afterwards. So I've pretty much eliminated most of the reasons why to do strip in women, and that's why I'm biased toward that. So I think we've presented a lot of information. Do you have any other words of wisdom for the audience or anything else in terms of your opinions?
I just want to add another thing, like I think is an advantage from my opinion, FUE, that you can select the grafts, especially when we're talking about the occipital area. You can select the thick and healthy grafts when you're performing FUE. I see it as an advantage in females or patients with limited donor supply. For me, in a nutshell, like in the first consultation, apart from assessment of the condition in the donor area, the key message for me to give to patients is, because hair loss, genetic hair loss, is progressive and chronic, they need to adapt to be on medical treatment. And medical treatments will always, whether they end up with a transplant or not, I believe they're going to have a better outcome at the end with the medical treatments.
That's wonderful. So I guess my concluding thoughts are that we are both very skilled and experts in our field, and we're very different in our opinions, and neither one is right or wrong. It's just what we find in our hands to work. A lot of times I talk about, just because one person said something, it doesn't mean it's right. And if someone else said something is not necessarily right. It's just different ways of doing things. And you've obviously had an incredibly successful practice and published a lot and really swayed the public to understand how your opinion it really works. And I've done a similar thing in my academic world and as well as my clinical world. So for me, I really have been passionate about natural therapies. They seem so far in the last really 2 to 4 years have really taken over biomedical, except for, as I mentioned, when there really is an instability of their hormones. And I have a very low threshold to work on women surgically, as I mentioned, compared to men. And I'm actually much more scared to work on men when they're young and they're unstable. And I want to watch them as long as I can on medical therapy, because you can't exit on it. And I've seen too many issues. Even in my past, I've had patients I've operated on prematurely that I regret, and I'm trying to learn from my own mistakes. So I really thank you, Dr. Zari, for this time. And I hope this little small video was helpful for the consumers out there. And thank you very much.
Thank you so much. I've really enjoyed this discussion, and I've learned a lot. And it's very interesting to see different opinions. And as you said, it's just different approaches of doing things.
Right. Thank you.
Thank you.